I want to start just by introducing our patient partners today that are with us. Dwight Parks from Newfoundland, and Gwen Harrington from British Columbia. They're going to be participating today as well. So thank you for this, the opportunity to tell you about our project, Strategies to Enhance Patient Self-Management of Chronic Kidney Disease. We thought we'd start off by just sharing with you our team members. And actually on the next slide, we can see the patient partners that are members of our team. Blair from Manitoba, Gwen, who's with us today from British Columbia, both Chantal and Claire Large here from Alberta, Nicholas Fernandez from Quebec, Dwight, who's with us today as well from Newfoundland, and Lucy Delgado from British Columbia. So those are our patient partners. And on the next slide, we actually have our investigator partners of the academic team and a number of individuals there. I won't go through all the names, but just to highlight Mo Donald, who's actually taking the lead in this project, and part of it is for her PhD program of research. She's actually not here today because she's in Italy on a bike tour, so enjoying herself there. Also want to recognize Heather Beanlands and Sharon Strauss, both of whom are co-leads on this project as well. So that's our team. So what we wanted.
Hi.
I think somebody else just joined us. What we wanted to do today was we're going to start off with a little bit of background information and have Gwen and Dwight both speak to their experience and to what chronic kidney disease means to them and how they got involved in this project. Then we'll tell you a little bit about why we picked this project of self-management and what it is. And then talk about the three phases that this project has. We've completed phase 1, and we'll go through those results. And what we really want to focus on, though, is our phase 2, because that's where we need some input from members, from patient partners and others who are interested in helping us out. And then we'll summarize at the end. So that's our plan for today. So just going to start off by having Gwen take over and tell us a little bit about herself and how she got involved with this project.
Hi. Okay, so I live in Dawson Creek, British Columbia, where I work as a public health nurse, and I was diagnosed with kidney disease in 2003, went through that journey of chronic kidney disease to dialysis and luckily to transplant. So for me, kidney disease, it created a series of losses, such as energy, feeling well, being able to work, time with family, even going to events, and what a person can eat. It's just endless. It's the losses that kidney disease creates. It's an erosion of the control that I had over my life. And so I joined CANSOL because this initiative gave me some hope of regaining some of that control over kidney disease. The premise is partnership between researchers and patients with equal voice. And that's appealing. I truly believe this type of partnership has some hope of doing research that's important and applicable and will help patients. So this project in particular dives deeply into self-management, and I love that because it has the hope of returning a sense of control to patients. And it's been wonderful to be a part of this research team. The researchers make it easy, they're warm, they're welcoming and appreciative of patient voices. I'm very grateful for the opportunity to be a lead with them on it. So my hope for this project is that it achieves what it's aiming to do, and that's to give patients their voice in self-management.
That's great. Thank you very much. Gwen has been a huge help with us in all aspects of the project to date, so really appreciate your input and look forward to the next phases with you, Gwen. And a more recent partner who's joined us is Dwight. So Dwight, tell us a little bit about yourself and your patient journey.
Yes, well, my story begins, I guess, 3 years ago. Up until that point in my life, 43 at that time, I was pretty healthy, just colds and flus. And what started out as an ear infection, landed me within 6 weeks in hospital, blind in my left eye, deaf in my left ear, my lungs full of granulomas and other flu-like symptoms, and I was diagnosed with systemic vasculitis. And for those of you who don't know, vasculitis is an inflammation of your blood vessels. I was lucky though, and lucky in quotes. So vasculitis usually attacks the kidneys, but at up to that point, I had no renal involvement. Vasculitis is treated with heavy doses of steroids and low-dose chemo drug. And it was during my treatment that my kidney function started falling. I was referred to a nephrologist and scheduled for a biopsy. And the state of healthcare here in the province, being as it is, or as it was, I guess it is, it took from when I seen the nephrologist, having my biopsy to getting the results, took about 5 months. And based on the biopsy, I was diagnosed with sorry, I will set up again. Chronic interstitial nephritis. So basically that means that my kidneys were scarred by a drug interaction. So at that time, my function was at 36%. My blood pressure was seriously high. My nephrologist basically prescribed some blood pressure meds, told me to cut salt out of my diet and set me on my way. So I agree with Gwen there about the loss of control, because basically I felt that I was just kind of cast out there. So I started looking for information on CKD, and not, I guess, to complain about my nephrologist, but his bedside manner was not the best. Basically, my questions were answered with a yes or a no. And to fill that void of information, I just Googled a lot of stuff. I found that there was a lot more to it than just to cut out salt. I realized I need to focus on the whole body and not just the kidneys. But following like certain steps, like eating the right food and exercising and trying to minimize stress, that I was able to control my blood pressure, and my function increased to 48%. But it didn't increase. Then that's where it stayed. So I found that I started to like look around in terms of like what was going on in research here in Canada and around the world. And by chance, one night last month, while I was on the Kidney Foundation website, I found a link to CanSol. And for me, CanSol was just an amazing opportunity to get involved in kidney research. I was able to contribute in some way to improving the lives of people with CKD. And it was during that the patient partner council meeting in Montreal that I chose the Selfmanagement project as one of the projects that I wanted to be involved in. For me, self-management is vital to maintaining my quality of life. It's the only thing that keeps my kidney function from decreasing. That keeps me away from dialysis or transplant. But I know there's like a lot for me still to learn, and I know that my experience with CKD is not unique in any sense. Many patients lack the knowledge and do not know where to get the information that they need to successfully manage their condition. I'm hoping that the project will go a long way to addressing that shortfall.
Great, thank you very much, Dwight. So as Dwight mentioned, he joined our team last month, actually, in Montreal at the CSN meeting. And we're really looking forward to working with you, Dwight. You've got great insights and perspectives, so a great addition to the team. So what we wanted to to move on to then is talk a little bit about self-management and why we chose this project. Well, actually, we didn't choose this project. It was the patients who identified this as a priority. What we did is a project that took place back in 2014-15, a one-year-long project where we worked with patient partners to establish research priorities for patients with chronic kidney disease. It was what's called a James Lind Alliance Priority Setting Partnership. So it's a partnership that involves patients in deciding what questions are important to them and what questions we should study. This is actually a four-step process. The first thing you do is you form a steering committee, and there are patients on that steering committee as well. Then what we did was a national survey to identify research uncertainties from patients with kidney disease across the country. We collated those responses and then had a one-day in-person workshop in Toronto where we went through the top 30 research priorities and came down to the top 10 research priorities. And on the next slide, you'll actually see a picture of the individuals who came to that final workshop, the one-day workshop in Toronto. And it was patients, it was caregivers, it was decision makers, there was nephrologists. So it was a group of individuals that established the top 10 research questions for patients with chronic kidney disease, not yet on dialysis. And if you look at the next slide, actually one of those top 10 priorities, and thing we heard a lot about from our patient partners during that process, was they really wanted to understand how they themselves could best manage their kidney disease. As you've heard both Gwen and Dwight speak to this, how can myself as a patient with the disease better manage the disease themselves? We heard a lot about patients who, as Dwight explained, felt isolated, felt that they didn't have the information to manage not just the kidney disease, but all the other aspects of living with chronic kidney disease, the psycho and social aspects of it as well. So that was one of the top 10 priorities that was identified through that project. And it was also identified when we, with our patient partners through the CANSOLS meetings and workshops that we had. So it remained a priority and was written into the final grant, and that's why it's one of the research projects that's being funded and worked on here. So we talked, and the patients talked a lot about self-management. Self-management really is, it's a broad term, and what it means is just the ability for a person working in partnership with their family or their community, their healthcare professionals, to manage not just the treatments, not just the drugs or the other aspects of the disease, but to manage the symptoms, to manage the emotional consequences, the social consequences of living with the chronic disease, as well as the cultural and spiritual consequences. So it really is a holistic approach in managing all aspects of living with chronic kidney disease. So when we talk about self-management, it's not just managing the drugs, it's managing the other aspects. Dwight and Gwen, if there are things that you'd like to contribute as we're going through, please feel free to as well. Or if there's questions as we're going, happy to answer those as well as we go through. So the broad aim of this project, and you'll hear about the phases of the project that we're working on, the broad aim is to develop a patient-specific self-management intervention that can be individualized to the patient's unique situation, their needs, their priorities, and their choices to improve their health and quality of life. The key thing is that it's patient-initiated. The patients will identify what this intervention is. We yet do not know what this is going to look like because it's still in evolution. But it will be very patient-centric and patient-specific to meet their unique situation and needs. The project overall has 3 phases. So the first phase that we've now completed, that we worked on over the course of the past year, and I'll show you some of the results today. The first phase was to see what is already known, what's been published in the literature, what are our clinics doing, the chronic kidney disease clinics across the country. what are they doing with respect? What do we know about self-management, and what are the clinics doing with respect to self-management strategies? So we did this in the fall and winter of the past year, and we will show you some of those results. The second phase of the project is just where we are right now, actually. And this is where we need your input and your help. So this phase is where we're actually going to be doing focus groups and interviews of patients and their family members to identify their experiences and what their needs are for self-management interventions. What do they think are important components of a self-management strategy? How should it be delivered? What are the key things that they want to better understand to help them manage chronic kidney disease? We're going to summarize the information from those focus groups and interviews, and then bring together the patients and caregivers, decision makers, and healthcare professionals at a one-day meeting in Calgary to summarize all that information and to begin to develop that self-management strategy. So that is going to take us into the fall and winter to move on to the most exciting part, is where we actually design and develop that intervention and start doing the testing and the implementation and the evaluation. Phase 3 is still a bit nebulous because we have to do phase 2. We have to understand the components and what's important for the patients before we can actually design phase 3. So those are the 3 phases of the project that we're going through. I'm going to tell you a little bit about the results of phase 1, which we have completed, to give you an idea of what's already been published. So the first part of the work, and this is a huge amount of work that was led by Mo Donald, was to do what's called a scoping review. So this is actually looking to see all of the work that's been out there that's published, but not just published work. We also looked at something called the gray literature, and that just means we also searched websites and internet and published reports to really pull together all the information. We had over 10,000 abstracts that were reviewed, and we narrowed that down to 46 that were the most relevant to self-management strategies for patients with chronic kidney disease. In some of the results, what we did is we looked at all that information and we summarized it, and we wanted to know what are the topics that have been included in self-management strategies in the past. The most common topic that was included was information about diet and nutrition, and that's something that we heard a lot from our patient partners as well that was important. The majority of the studies, 25 of those 46, were actually about diet and nutrition. The next most common topic was medication, and the information on medication was both what medications can we use to slow progression of kidney disease, but also what medications can be harmful to the kidneys as well. And then the other topics were just general knowledge about chronic kidney disease, kind of a smattering of other topics, and then information about physical activity, information about modalities of the different types of renal replacement therapy, like hemodialysis or peritoneal dialysis. Some information about comorbidities were addressed as well, about different conditions that patients may have living with chronic kidney disease, such as diabetes and hypertension. And surprisingly, very few about symptom management, such as fatigue. You heard Gwen speak about the fatigue and the symptoms that she was experiencing, but in the published and related literature, there wasn't a lot of information about that. And also about lifestyle. And again, you've heard both Dwight and Gwen speak to the importance of lifestyle, but very few of the published and related literature focused on that in the self-management strategies. So again, the most common topic was diet and nutrition. The most common delivery format was in face-to-face, either on a one-on-one session or in a group type of education session. That was the most common. The next most common type of format was multiple formats. It could be print materials as well as face-to-face or online, just meaning that it used more than one type of delivery method. And then print materials were the next most common, followed by distance modalities such as telephone or email, digital like DVDs, PowerPoint, and then finally electronic were one of the least common, and although the most recent articles were more likely to have electronic, so it depended on when the articles were published as well. So the most common delivery format was face-to-face. The most common providers, like in terms of who actually gave this information, was a category called other, and that included individuals such as kinesiologists or pharmacists or social workers, so a group of other types of healthcare professionals, followed by nurses or nurse practitioners, then dietitians, multiple providers, and then social workers, physicians, nephrology fellows, or patient volunteers or mentors. So the most common providers were a variety of other healthcare professionals or nurses. So that really is a sense of the literature, or what's known out there in the literature in terms of self-management strategies. The next thing that we did, and Sarah Gill had a huge role to play in this, was what we called an environmental scan, where we actually sent a survey out to all the CKD clinics in across Canada to ask them what sort of topics and delivery formats they were using in their clinics. And we asked them specifically, we said, for your patients who are not yet on dialysis but have chronic kidney disease, what are the self-management strategies and interventions that you're using? The majority of the topics were actually with respect to modalities, so talking about renal replacement therapies, choices about the type of modalities. Then the next most common was nutrition and others. And comorbidities less common than that, and medication. But the most common in the clinics across the country was discussion about modalities. We also asked them about the delivery format, and similar to the published literature, they were using a multiple different types of format, using a combination of print and electronic and face-to-face, or some distance as well, but usually a combination of a variety of different formats are being used in these clinics. And then with respect to who is providing the different types of interventions, the majority that was being provided by nurses, the majority, but by far the majority, followed by dietitians, and then social workers, nephrologists, pharmacists, and then patient volunteers. But the nurses in the clinics really were the majority of the providers. So what does this all mean? So it was a huge amount of work to kind of summarize what was out there, but we thought it was really important that we did that because we wanted to really build on what we already knew. And more importantly, we wanted to identify what the gaps were so that we can focus on the potential gaps as well. And really what we found, what was missing in these self-management interventions, was that none of the interventions at all were designed by the patients, for the patients. They were typically designed by providers or the researchers, but none of the interventions were designed by the patients or with patient input. So anticipating that if that was the case, they probably didn't specifically address the patient needs or preferences. So that is a major focus of the work that we're going to be doing, is really to have it designed by the patients based on their needs and preferences. And the other thing that we noticed is that none of these interventions that were developed were based on a proven framework or clinical guidelines. There's something to help frame the intervention, and so we'll be taking that into account as well as we develop our own intervention. So moving forward then, that gives you a sense of what we did in phase 1. And now we're moving on to phase 2. So this is really where we're focusing on now. So if you just click on the next slide, this will bring us into phase 2, where we're going to be using focus groups and interviews to find out the experiences and choices and needs of the adults with chronic kidney disease and their caregivers. So really asking them what their needs are with respect to self-management. And we're still going to be very broad. We're not calling it a tool or a strategy. We're being very general because we really want to find out from the patients what specific aspects are important to them. So this is where we need your input in terms of identifying potential patients who are interested in participating and helping us to recruit both for focus groups as well as interviews. The types of patients that we're going to be focusing on are those who have chronic kidney disease. We're not specifying a specific level of GFR, although we anticipate that most patients will probably have a GFR of less than 60 and are aware that they have chronic kidney disease, but are not yet on dialysis. So we really want to focus on the earlier stages of kidney disease to help them manage those earlier stages. So that we want patients with earlier stages of kidney disease, as well as what we call informal caregivers. So that could be relatives or family members or friends who help or assist the patients in managing their illness. They have to be able to read and write and speak in English, because that's how we'll be doing the focus groups and interviews. And we're going to be doing the focus groups in Calgary and in Lethbridge, as well as in Toronto and London, to get a broad perspective. But in addition to the focus groups, we really want to make sure that we also include patients from more rural and remote locations. So we'll be doing telephone interviews with patients and their caregivers from anywhere across the country. I'm just going to stop there just to see if there's any questions or comments about this phase and the focus groups and interviews that we're wanting to do. Or Gwen and Dwight, if you had any comments or comments you wanted to make.
Brenda, it's Braden. Just what you highlighted was that a lot of the tools already out there are around helping people choose what type of dialysis or what type of treatment. So it sounds like maybe where the gaps are going to be in people with earlier kidney disease, and I think you've identified some strategies, and you're right, maybe the patient council can help you find people with earlier kidney problems. Is there a way to identify people who are like even in primary care where most of kidney care occurs, or did maybe the patients have some ideas of how we access those types of people who aren't seeing kidney doctors?
That's a great question, and that's really the target that we want to get, is the patients with the earlier stages of chronic kidney disease. So I'd really appreciate the input from the patients as to how they think that we might be able to access them. We thought about putting up posters in primary care physicians' offices where they could then phone into a number and express their interest and call in. But if there's other suggestions about potentially identifying that patient population.
I mean, the local kidney foundations, do you think that they're, I don't know if one of them's on the phone, if Liz is on the phone, but I wonder if their call out, or their, like their email addresses that they have and their mail outs, and maybe even their Twitter list, I wonder if they include mostly people with more significant severe stages, or if they get some earlier people as well.
It's a good question. I don't know if anybody is on from the Kidney Foundation, but that's a great suggestion as well. We will post this on the Kidney Foundation, and also use social media as a mechanism to let people know what the opportunity to participate.
I see that Paul has raised his hand. Did you have a question that you wanted to ask, Paul?
Paul, I wonder if you might be muted. Paul, are you still on the phone? I can see you there. Your phone might be on mute as we can't hear you. While Paul is maybe sorting out the phone, I know Joanne Koppel's on the line. Are you going to be targeting Indigenous communities at all to understand what their needs are? Or I assume you're not doing pediatrics, although maybe you are.
Again, great questions. We're not specifically targeting the Indigenous populations or communities. You know, Joanne has been doing work in that area, and we're collaborating with her in terms of work that we're doing, what she's doing, but we're not specifically targeting that patient population. And Susan Samuel, who's a pediatric nephrologist, is a member of our group, but we're not targeting specifically the pediatric population either. This is adults that we're going to focus on with this intervention, recognizing that there could be some future projects and things from this that we glean that might be able to help identify that, some strategies for the pediatric population.
Thank you.
Okay. If there's no further comments or questions, maybe we'll just move on then. So the next slide. So what we do, after we do the interviews and focus groups, we're going to summarize all that information and then have what we call it's called a modified Delphi, a nominal group technique, where we bring the information together in broader themes and then work together through a face-to-face consensus meeting to really discuss in greater detail what this intervention, the components of the intervention are going to be. We'll talk about the topics and the areas of self-management support, talk about the delivery format. So really now at this meeting, we'll start to prioritize and start to frame what that intervention is going to look like. I anticipate that probably what we'll get is not just one intervention, but there might be a couple of, or maybe even several different types of interventions that come out. We'll only be able to, I assume anyway, focus on one for the purposes of this project, but there could be other future work that we do and that this background work will help to inform. So this meeting will include, and again, I look to the patient partners here because we'll really value their input at this meeting in particular. This meeting will include patient partners as well as their caregivers, healthcare professionals, and other decision makers who provide care for patients with chronic kidney disease. It might be some people who are in our focus groups in the past or in the interview participants, but again, they'll have to be able to read, write, and speak English, recognizing that is going to be a limitation. We're going to have to limit this to English and possibly in the future develop interventions in other languages, but for now, this is going to have to be in English. And we're anticipating that it's going to be in Calgary, the one-day meeting. So again, that is really where we are right now over the fall and winter, focusing on phase 2. We've submitted the ethics application here in Calgary. We're looking and working with our co-investigators in Toronto and London to get the information and ethics underway there, because that's where we'll do the focus groups. But our interviews are going to be from across the country. So we're really hoping that we can get input from individuals across the country and look to our patient partners for assistance with that. And then finally, the third phase is where we'll be moving on to after we've had that consensus meeting. And this is really going to be the most exciting. We're going to develop what we call persona scenarios, so different types of scenarios to help guide us in developing. We think it might be a web-based intervention. We put that down there just to kind of give a bit of context to this. It might not be a web-based intervention, but we'll develop some persona scenarios, and that just means that we'll have different examples of different case studies, like a female with chronic kidney disease of a certain level, with certain issues that they may be interested in understanding better, so different scenarios to help guide the development. We'll have to do some usability and pilot testing of the intervention, as well as develop the KT strategies around it, as well as the evaluation strategy, which is most likely going to be what we call mixed methods. So we'll evaluate both by doing interviews, so speaking with the patients that are using the tools, as well as possibly surveys. And then also incorporating what we call a sustainability plan, or just considering other components throughout the project, so how we can make this broader. What we want to develop is something that could be used by CKD clinics or possibly primary care clinics, or broad-based tools that are open access and available more broadly to patients across the country. So we don't want to have it specific to a single clinic. We want to make it a lot more general in nature so that it can fit the need of a broader population base. So that, in a nutshell, is our self-management project. I hope we've been able to show you why we focused on this project specifically and what self-management is. It's a broad concept, but it's important that we think broadly as we're developing it. And most importantly, it's important that we engage our patient project partners in the development of something that's not been done in the past. We summarized the phases for you and showed you a little bit about our phase 1 findings, and summarized, I hope, for you where we are now with respect to our next phase and phase 2, where we need additional input. And we'll keep you posted for phase 3 as it comes through as well. I'm just going to stop there and see if Dwight and Gwen had comments about the phases and where we're at currently.
No, it all sounds good to me. Like, whatever I can do to help, I'm here. I wish that I had something like this when I was first diagnosed, I must say, right? You're trying to deal with the burden of just the trying to come to grips with the fact that this is the way that, that you're going to be for the rest of your life, and then have to very quickly find the information that you need in order to, maintain your quality of life that you have.
Thank you, Dwight.
I'm excited about the next step, to do the focus groups and see what everyone thinks.
So questions from across the nation?
I'll just jump in to say that, Paul, if you're still having any issues with your audio connection, you can type your question into the chat window, and I'd be happy to read it for the group.
I don't know, Brenda, if you've already gotten your ethics for the next phases of work, but I wonder if your CKD pathway, which I think is broadly used in primary care, like especially some of the patient tools, do you think you could add a little invitation on that web page saying, we need your feedback, we're developing tools to help patients just like you, and you might get some people that are interested from across the country.
That's a great idea. So we've got online a tool that's called, it's www.ckdpathway.ca. It's a tool that talks about diagnosis, management, and referral of patients with chronic kidney disease. It's targeted and tailored more for healthcare professionals than it is for patients. Our aim is actually to develop something similar for patients. We haven't pursued that yet because we really want to get this information from the patients at this next phase to see about the important components. We will link on a patient tool with additional information for patients, but I think once we hear from the patients what information is important, we will update and modify that existing tool as well. But you raise a very good point, Braden, about if people Google it, and we do get a number of hits on that, and I'm sure a number of them are from patients, and so we can look to incorporate that as a potential tool or mechanism to recruit patients and providers as well.
Other questions?
I just had a question for Dwight. Dwight, when you talked about first being diagnosed with chronic kidney disease, sounded like one of the first places you went to was the internet and you Googled it. So was that a good source of information for you? Are you assuming that there might be that as a tool?
Yes and no, just because there was so much of it. And a lot of times you had no idea about the source of the information on the web page. So, and I also came across sites that could cure CKD as well. You just need to take these herbs and whatever, and you're good to go, right? So you have to be careful. And I found sometimes too, some of the websites said that this food was fine to eat, and this website said that it wasn't. So it was confusing at times, right? Really what to believe, I guess.
Mm-hmm. So it's finding credible information and accurate.
Exactly. Yeah, it's all about that, right?
Very interesting. I do wonder, Brenda, whether the kidney foundations might be able to help to spread the message that you're looking for patients and you're looking for patients' input. Karen Thomas would likely be able to help, and I suspect some of the other kidney foundation branches would be pleased to do that as well. I know Paul has a role with the BC Kidney Foundation branch, or his wife does, one of the two. So I was wondering if that might be what he was going to talk about, but
that's a great suggestion, and for sure we'll link in with the Kidney Foundation across the country, actually the various branches, and have them post on websites and get the information out broadly. Because we really want to get, especially patients in some of the rural communities, because I'm anticipating that some of the needs in the rural or some of the more isolated settings might be a bit different than some of the patients in the larger cities. I don't know, but that's what we'd really like to look at as well.